Hello, everyone. Welcome again to the Trauma Anesthesiology Society podcast. Happy to let everyone know that we're recording today on St. Patrick's Day. I am again Joshua Sappenfield here at the University of Florida, and my colleague is Dr. Kevin Blaine at OSHU. We're very excited today to be joined by Dr. R.A. Shander, who is the Chief of Anesthesiology at Inglewood Hospital and Medical Center in Inglewood, New Jersey. He's a professor of anesthesiology at Mount Sinai and a current president of the Society of Advancement in Blood Management. Welcome, Dr. Shander.
Well, thank you. Thank you very much for that kind introduction, and happy St. Patrick's Day to everyone.
We invited Dr. Shander to speak to us today about blood management in the setting of trauma. I trained in Baltimore, Josh did too, where it felt like we gave buckets of blood to every major trauma patient we saw, but of course, there were also bleeding buckets of blood. But immediately after following my fellowship there, I did another fellowship in blood storage and conservation at the NIH, where we were encouraged, in a nutshell, not to transfuse anyone ever. So, as someone who's very interested in blood transfusions and trauma, when I left my two fellowships, I was absolutely perplexed about what I should do. So, Dr. Shander, is a trauma hemorrhage the same as any other surgical hemorrhage?
So, again, to very quickly respond to that, I could tell you that there's always a place in the middle, if you will, between no transfusion and always transfusing. I think that when you deal in terms of the pathophysiology or the mechanism of hemorrhage associated with a coagulopathy, which is what we deal with in trauma, you're dealing with essentially with a different pathophysiology and possibly a mechanism of the coagulopathy as compared with, say, postpartum hemorrhage as well as cardiac bleeding. Uh, they may represent, at least to the naked eye, they appear the same. Patient is bleeding and is becoming unstable. But what is driving the coagulation abnormality and what is driving the bleeding, besides the trauma, meaning the trauma to vessel, the trauma to the uterus or placenta, and the trauma to the cardiac vessels, is different elements of coagulations that are missing or they're not properly working. So I think that when you keep in mind that the mechanisms are different, we need to have a different approach. Unfortunately, what we're seeing right now is that we start off with trauma at the 1-to-1-to-1 ratio, if you will, and we immediately extrapolated that to all types of hemorrhage, despite the fact that they may not be the same mechanism.
Well, just to dive into that, in general, is there a downside to transfusing blood?
Um, as a default, there is a downside. We know that transfusions of allogeneic blood are associated with a negative outcome. Now, people talk about the blood saves lives, but in fact, blood is just one part of a resuscitation armamentarium that we have. And if you think of blood as an organ, we reach for the organ before we've done everything else. As an example, you don't when the creatinine goes up, you don't transplant a kidney into a patient. You go through a whole slew of things before you end up with the last stage, which is a transplant. If you think of any other organ, usually the transplant is the last intervention, not the initial intervention. But we've become so ingrained as a reflex that we actually don't think of the risk of transfusion for patients. We just think in terms of the risk to us, if you will, if we don't transfuse. So even in trauma patients who are coagulopathic and bleeding, there is somewhere between 30 as high as 35% of patients are over transfused, meaning that they come out of surgery or whatever manipulation is being done with a higher hemoglobin than they did coming in from the street. And we see the same in other areas of medicine where we deal with hemorrhage. Now, the risk is clearly dose related, and transfusions per se don't stop bleeding. And I think that if we can change the mindset that we need to stop the bleeding, meaning the surgical team, needs to stop the bleeding, and then the appropriate resuscitation. And if we're dealing with a coagulopathy, we need to identify what's missing in the coagulation symphony and then replace it appropriately, which may or may not mean transfusion. So in context, is transfusion a bad thing to do? I think it's not necessarily transfusion or blood is bad. What I do think is that our behavior has been ingrained as a default that if you see a low hemoglobin or if you see a prolonged PT, that we reach for blood components without really understanding the risk to the patient and what other alternatives means that we have to address those conditions.
Well, hopefully that was enough to fully convince our listeners, because I was convinced before we had the conversation. But I mean, you answer if the transfusions have a downside, but is transfusion actually a very effective therapy? I mean, for example, do red cells increase oxygen delivery?
So when you look at the blood establishments publications, they're always talking about the safety of blood. Um, very few situations or very few manuscripts have been published on the benefit of blood. And like everything else in medicine, we always have a risk-benefit ratio, whether it's chemotherapy or any other situation where the risk is outweighed by the benefit. We have never had randomized controlled trials the way we do with other pharmaceutical or biological agents when it comes to blood. FDA has resisted this, and their response is that this is basically a time-dependent proof that the blood works, even though we don't have that. Now, normally we think of delivery of oxygen with hemoglobin. But when you, and I think everyone on this call, on this podcast, remembers the oxygen delivery formula. And in it, clearly hemoglobin has a considerable weight. But what you don't know is whose hemoglobin is that formula addressing. Is it the patient's hemoglobin? Is it stored blood hemoglobin? Or is it the volunteers who help create that formula in terms of the hemoglobin? Because stored blood does not deliver oxygen in the same fashion. Now, oxygen delivery in with a transfusion usually increases, but ultimately what we want is not the delivery, because we can improve delivery with other hemodynamic parameters that we could use, but we need oxygen utilization, VO2. And transfusions do not consistently, in matter of fact, less than 80% of the time do transfusion actually improve VO2. So they deliver the oxygen, but you're not getting the end results in terms of improving oxygenation. And other benefits in terms of survival are also questionable right now. So we have other clinical measures where we don't have a very good understanding in terms of the benefits of transfusion. And it's not just red cells. We're also talking about plasma as well as platelets. And I think that we are sort of still using conviction that loss of blood should be replaced with blood, regardless of what is the underlying mechanism of the disease, and that the replacement of the blood, which is coming from the blood bank, is actually effective. So the numbers may change, your hemoglobin may rise, but at the same, or your platelet count may rise or not rise, and you know that about 50% of the time platelet counts does not rise. And that's another conundrum, which I'll address in a second. But the fact is that we really don't have a good handle, or we can't really put our arms around the actual benefit of transfusion. And just saying that transfusion save lives, I think, is misleading. I think that there, as I already mentioned, part of the resuscitation armamentarium is used appropriately. But currently, it's a default with, again, nowhere do we have good benefit. Now, the platelets issue is that when you're hemorrhaging and you give platelets, 50% of the time your platelet count doesn't come up. Are we looking for a rise in platelet count? That would suggest that we're not actually utilizing the transfused platelets. If the count doesn't go up or even actually goes down, you may actually stop the bleeding because the platelets are actually effective and being utilized and consumed. So again, you could see that we're really not sure what it is that we're looking for in terms of benefit of most of the components of blood that we use.
I mean, that's really interesting about the platelets there. I mean, do plasma and platelets or even cryoprecipitate improve clotability in trauma?
Well, it depends what the coagulation defect is. If fibrinogen is deficient and you need fibrinogen to clot, I could tell you that by giving lots of plasma, you actually dilute the fibrinogen, especially, for example, in hemorrhage due to trauma and also in postpartum hemorrhage. I think most people know that the parturient has usually the normal fibrinogen level is almost twice that of normal. So even if you have a normal fibrinogen level and somebody who's got postpartum hemorrhage, that fibrinogen is low and may actually interfere or be a defect in terms of clotting. And we know that fibrinogen gets consumed very early in trauma coagulopathy too. And the amount that fibrinogen that's required again to replace it, you're going to need a significant amount of plasma. But you're only giving plasma in ratio to the other units of red cells and platelets, not necessarily to again address the defect. And you mentioned already before the issue of concentrates, and I think our colleagues in Europe and other parts of the world have diverted now from the ratio-driven resuscitation to more of a goal-directed and look at the components, if you will, of coagulations that are missing and replace it. So you can effectively replace fibrinogen with a fibrinogen concentrate with very low volume, so it doesn't dilute everything else. Yet, if you're going to do it with plasma, you're going to need multiple units of plasma to reach the same concentration of fibrinogen. In addition to that, if there is a situation where you actually require high concentration of fibrinogen, you'll never reach them, meaning above 2 grams. You will never reach them with plasma because, again, keep in mind that's donated and it's donated from the general population, which has a normal fibrinogen level at best. But with a concentrate, you can, again, reach higher concentration of fibrinogen. All that's clearly controversial in terms of standardization, but our colleagues in Europe have really, for the same injury severity score, have a much better mortality data than we have in the United States, despite everything that we do.
Great. You mentioned ratios, and I want to ask you about that because I feel like massive transfusion in trauma today in 2021, at least in the United States, it's all about these 1-to-1-to-1 ratios. And balanced resuscitation, if you want to call it that, that's part of ATLS now. So it's pretty deeply ingrained in trauma resuscitation ideology. How convinced are you by the literature supporting 1-to-1-to-1 transfusion ratios in trauma?
Okay, so it's pretty easy to argue. First of all, ATLS, there's a lot of issues we've had with the ATLS algorithms to start with. In terms of, again, the degree of volume loss and expression of clinical shock. But be that as it may, I think that if you look at the literature that you suggest supports the 1-to-1-to-1, it is pretty weak. And we started off with the issue of again, from the military, where the first publication was a observational one where they looked at the ratio, and as they drove the ratio down or up to more closer to 1-to-1-to-1, there was a significant reduction in mortality, which was not absolute, by the way, but relative. But the numbers were very, very big, and everybody gasped at them and said, okay, we need to adopt this now across the board. When the same group did this in civilian injuries, I think that we can argue that the data was not convincing. However, the statisticians clearly made it look like there was an advantage of the high ratio, meaning 1:1:1, as compared to the low ratio as you drove it down. So I think that the literature is not as strong as it should be in terms of support, and many of those participating in prospective trials were already convinced that 1:1:1 is the way to go. One of the issues that for years has, I guess, confounded the findings that we have is the survival bias. And even in the initial one, we knew that it takes time to get plasma. So the question of survival is, do you survive long enough to get all the plasma to reduce the ratio? Or or the individuals who did not get the high ratio perished early on. So survival bias is something which has been clearly studied all throughout the literature as we following the progression of publications on the 1:1:1. The one that I think seemed to be a gift that gives everyone was the proper trial done in the United States. And the proper trial, the reason I say it's giving is because if you are a supporter and proponent of the 1:1:1, it was a positive trial for the 1:1:1. If you are a skeptic in terms of the 1:1:1, then you could say that it was not a positive trial, and both sides can win their argument independently. And there have been critiques published in the literature, again, not necessarily unsupporting, but clearly critiquing this particular trial. In addition to that, there have been other publications looking at pre-hospital administration of plasma. And I think that some of those are confounded, seriously confounded. And the two big ones are actually conflicting because one saw no difference and the other one saw a difference. And when you also look at some of the literature that's been published on going back to the 1:1:1 ratio, you could see that the number of units actually given on both sides of the aisle, meaning placebo or standard of care versus the 1:1:1, it wasn't placebo, if I'll retract that. But those trials, at the end of the day, the difference in terms of the number of units given were not dissimilar, suggesting that there really is not a big difference between the two. And in addition to that, when you look at the injury severity score, the ISS was the major driver for either survival if it was low or for mortality if it was high. So these are very confounded, and I think that we're starting to get better at damage control surgery. I think we're also getting better at evacuation without significant resuscitation. I think there are many factors that have contributed to the improved in management and survival of trauma patients. And I really don't think it's due to this particular approach in terms of transfusion, and that I don't think that the literature is strong in terms of supporting it. So going back to your question, one can make the argument. It doesn't mean that something that's been published makes it true. And when there's a lot of publications that are for and against, meaning that the data one is positive, the data and another is negative, I think we have to stop and think maybe we're not asking the right questions, or we may not have the right hypothesis, or our methodology may not be the right one in terms of addressing the outcomes that are being measured in these trials. So I think it's still easy to not necessarily refute, but to argue against this ratio driven and start looking at the goal-directed therapy. I don't know why we're giving platelets when platelets are not needed, but it's part of the 1:1. So if you want a recipe, you have it. I think though that if we are smart and look at massive transfusion protocols in terms of what's being delivered to the area, and then identifying the defect. You're in the blood components are now available at a hand's or moment's notice, and that's what the massive transfusion protocols should do, is deliver these components if needed, including, by the way, concentrates when needed too. So, I know it's a long-winded answer, but I think that there is justification to challenge some of these recommendations based upon the fact that the literature, I don't think, is definitive.
I agree with you about your comments, Dr. Shander, about the endpoints for most clinical trials. Josh and I have kind of joked that a big clinical trial will get published in trauma, and the results, the primary endpoint will be negative, and then the secondary endpoints will be mined to make whatever point the authors wanted to make in the first place, or whatever point the critics want to make. So it's tricky to interpret, particularly the proper trial, even though it's the best trial that we have. Their control arm was a 1 to 2 to 1 ratio. I wonder, do you think that the issue is that the ratio itself is wrong, or the entire approach to ratios is wrong?
The quick answer is both. I think that what they should have done is look at standard, meaning what we were doing before any ratio came into the into common practice, and compare that in a prospective manner to ratio driven. And even there, in the ratio driven, they didn't meet all the criteria in terms of achieving a low ratio. I think that 1 to compared to 1 to 2 to 1 is just too close. And actually, I don't think it was 1 to 2. It was 1.1 to 1.2 to 1, or somewhere in a fraction, if I recall. So I think that regardless whether it's 1.1 or 1.1 or 1.2, that is just too close to make a difference in terms of any kind of therapy. If you think of it, the contents of clotting factors in a unit of plasma and the contents of clotting factors in 2 units of plasma are not going to be that more, they're not going to double necessarily. But keep also in mind that, and I mentioned this in the beginning, the 1 to 1 to 1 is 3 components: red cells, plasma, and platelets. And the count is wrong because every unit of platelets is essentially a unit of plasma. So you're looking at enormous amounts of plasma. And I think that that's a confounder in many ways. And I'm not sure the platelets are needed to start with. And it depends again on the type of situation. Now, I could tell you that this has been extrapolated to postpartum hemorrhage, and obstetricians are calling for platelets, where these women don't need platelets. They need mostly fibrinogen. Essentially, what they need is to stop the bleeding. The same with the trauma patients: stop the bleeding. And then you'll have a better idea of what you're dealing with in terms of what needs to be replaced, or whether you're dealing with an ongoing coagulopathy that needs to be stopped.
At my institution, we're moving away from 1 to 1 to 1 and towards whole blood, cold stored whole blood. What's your opinion? What's your experience with whole blood? And is this something we should be using?
Well, we started off with transfusion medicine with whole blood. And then again, due to the wars, we've now been able to separate the different components. And more than that, actually derive a significant number of different concentrates, all the way down to IVIG from plasma. Um, you know, there are a couple of things. First of all, the advantage of whole blood is that every unit of whole blood comes from a single donor. So again, the exposure of proteins, and we're not talking about HIV, hepatitis B or C here, because those clearly are low frequency. They're not zero and they're not gone away, but they're really not a major concern. The major concern is immune modulation, meaning the amount of foreign proteins that we introduce to a patient when we give a unit of blood component. So I think you're reducing that exposure by using whole blood. But think of it in terms of the logistics, and you're moving towards whole blood, but whole blood clearly is limited in storage because of the platelets, and at the same time, because you're not separating out the different components, your supply is going to be extremely limited. So again, from an inventory point of view, this is going to be a huge strain if this opens up for everyone in terms of the supply of blood. Because as you know, one of the major issues the blood establishment has is retaining donors and retaining repeated donors. And whole blood is going to require a step up, if you will, in terms of donation to maintain inventory. So you have some advantage in terms of reducing exposure. You have clearly a challenge in terms of inventory. And the biggest challenge in my mind is we have not been able to demonstrate yet that this has any benefit over goal directed. I hate even to say benefit over one-to-one, but I don't think that we are there yet. I know that there's a lot of conviction out there, and the same conviction is what I think drove the one-to-one rather than actual science.
Well, everyone likes to talk about transfusions, but one of the things that isn't covered much is about blood sparing techniques in trauma. I know you're active in the patient blood management movement, and a lot of those recommendations focus on preoperative optimization, like correction of anemia and so forth. Is that even realistic for trauma patients?
I think that the trauma patient represents a different type of challenge. I think that, again, if you look at blood sparing activities, they are sometimes looked upon as being finite, meaning that we want to eliminate completely blood transfusion. But when you look at patient blood management, most of it is looking at elective, but it does not preclude the urgent case or the trauma case or hemorrhage. Now, again, the idea here is that blood components do not stop bleeding. So the first rule is to stop the bleeding. And once you stop the bleeding, you take a step back for a second and evaluate what needs to be replaced. Now, if it's a young individual or someone who does not have a lot of comorbidity and they are tolerating a hemoglobin of 5, and they don't have a dysfunctional bone marrow, I could tell you that they will replenish their red cells pretty quickly. If they have a functioning liver and they're teetering on, say, a prolonged R or even a reduction in terms of the clot strength, they will produce platelets and they will make more of the components in plasma. So the question is, do we just resort to checking the numbers and replenishing it with allogeneic components, or do we make an assessment across the line of all of these components and say, in terms of the patient, and say they can tolerate the hemoglobin while we're treating it? And by the way, the treatment will result in reticulocytes almost instantaneously within the first 12 to 18 hours. And keep in mind, even though you may have a hemoglobin of 5, if you're reticking and reticking actively because you have the substrate to retic, which is usually iron, your delivery and unloading is actually better than the hemoglobin of 5. If you have a hemoglobin of 5 and you're not reticking, that may be a situation where you may have to consider transfusion. The same goes for the plasma. We may have abnormal thromboelastography on these patients, or we'll even PT and PTT. But if they're not actively bleeding, we can follow, and usually this will correct. And if need be, we can supply sometimes the individual patient with concentrate if we consider that this is a bleeding situation, depending on what's missing. And the same goes with platelets. You will recover the platelets. So again, I think that once you mechanically stop the bleeding, from a trauma that we need to reassess in terms of replenishment, just the way we do in patients who are bleeding in the operating room who may not have trauma. So again, those may be stable with vital signs, but again, I think we could stabilize patients without necessarily giving transfusion when it comes to, again, loss of whole blood due to trauma. So there are things that we could do. In addition to that, I think there are pharmacological agents that are being used. We've published already a few critiques in terms of this wide indiscriminate use of antifibrinolytics, namely tranexamic acid versus epsilon aminocaproic acid. But I think that all of these have a role in terms of supporting the patients during trauma resuscitation. Now, the likelihood is that many patients will most likely require some blood components. However, as I already mentioned to you, if you're concerned with benefit and risk, we do know one thing, that the more you get, the higher your risk of developing both morbidity, and the data also shows increased mortality with a high number of transfusions. So anything that we could do to reduce the exposure of the trauma patient by utilizing clinical judgment, clearly addressing the bleeding ASAP, being conservative with resuscitation, and then appropriately addressing any of the defects, you will end up conserving blood, and also I think we'll have better survival.
So, just to highlight one of the things I think you said, because I hadn't thought about before, it sounded like you're suggesting in the first 24 hours we should be assessing to see if our patients are making reticulocytes. And if not, we should probably be working them up to see if they're missing any substrate to making red blood cells.
Well, think of this way. Rule of thumb: you lost blood in the field. You're coming now to the operating room. We fixed the defect that you have surgically, and now we're resuscitating you. What you have, and your hemoglobin has dropped, say, from 13 down to 9 or down to 7, whatever number you want. What you have is essentially what's called iron deficient erythropoiesis, or iron restricted erythropoiesis. Every time you lose a red cell, you're losing iron. So you can draw on your iron stores, but your iron stores are not letting go of iron as quickly as you like them to do. So adding exogenous iron initially, which a lot of people don't do, um, is most likely wise, because at the end of the day, you're replenishing the iron that's lost, but two, you're also making iron available for transport so that new red cells will incorporate the iron. Iron gets incorporated late in the production of red cells, not early. So this will help release red cells, and what you'll see is increase in reticulocytes. And reticulocytes are ready to work. They're fresh, they're young, and they're full of gusto. So your delivery is going to improve despite the hemoglobin delay, from the therapy. But we generally don't do that. We generally just transfuse these patients. And transfusions, by the way, will suppress erythropoiesis, endogenous erythropoiesis.
Well, great, thank you. We're nearing the end now. I'd like to close by asking you about the knowledge gaps for transfusion and trauma. What do we still not know, and what data do you think we would need to look out for?
So what we don't know is enormous. First of all, we don't know uh, whether each of the components that we give, despite whether you're using one-to-one or goal-directed therapy, is actually going to do what it is you think it will be doing. You give them with the understanding that they may help. But at the same time, we really don't know how many individuals have perished due to transfusion in the trauma setting, because no one will ever suggest that a transfusion may actually do the reverse, meaning harm the patient, or actually, for the lack of a better word, cause the demise of that patient. And keep in mind that anaphylactic reaction or reaction to transfusions are certainly rare, but under the circumstance of a large number of components, that is still a possibility. But we always think in terms of the demise, not from the intervention, but from the actual injury of these patients. So I think that we really don't know how well this particular therapeutic intervention of transfusion of blood components is actually helping all patients. And you could say that, after looking at 100 patients, if you give transfusions to all of them, say 60% survive versus giving no transfusion, only 30% survive, therefore transfusion is positive. But we don't have that kind of data. We always have data in terms of how much transfusion has been given rather than other appropriate interventions when there are appropriate, such as I just mentioned before, in terms of monitoring patients. So there's a lot that we still don't know. And we are still looking, specifically in trauma, we're still looking for transfusion of blood components as the savior for the patient. And I think what we need to concentrate is on all the different elements of, again, a resuscitation that we have, whether it's damage control, whether it's appropriate resuscitation, um, and and again, also identifying any kind of defect that the patient may have in terms of coagulation. So I think we need to expand our horizon, and I think we're shackled to the idea that transfusions save the trauma patient and that transfusions basically stop the bleeding, and we know that that's not the case. So there's tons of work that still needs to be done. But I think what we need to do is to also start opening our horizon to think in terms of other modalities, not just transfusion as being the default, which it is right now in most trauma situations.
Well, great. This is a high chance of being my favorite podcast yet. Thank you, Dr. Shander, for your time today. I've really enjoyed this discussion. I think our listeners have too. We like to thank our host, Doc Matters, for supporting this discussion once again. We encourage comments to be posted following the discussion, and we'll try to answer them as they pop up. Look forward to having our next discussion.
Well, thank you both. Thank you all actually for putting this together, and it certainly is a privilege to share your time together. So thanks.